This is Evan Winrick, presenting on behalf of myself, Dr. Apar Dadlani, and Dr. Christine Kruger, all from the University of Louisville School of Medicine. Today, we present a rare case of AIDS cholangiopathy in the setting of recurrent Cryptosporidium infections. A 48-year-old male with COPD, HIV/AIDS with most recent CD4 count of 34, and previous Cryptosporidium gastroenteritis presented to us with nausea, vomiting, and nonspecific abdominal pain. Labs on admission demonstrated transaminitis and an elevated total bilirubin. CT of the abdomen showed new intrahepatic and extrahepatic bile duct dilation with no stone in the bile ducts. A follow-up MRCP confirmed moderate intrahepatic biliary ductal dilation involving both right and left lobes of the liver with mild dilation of the proximal extrahepatic common duct. Importantly, the study additionally showed no evidence of cholelithiasis, gallbladder sludge, or measurable extrahepatic ductal stone. Autoimmune workup was also negative, ruling out primary sclerosing cholangitis. ERCP was performed and revealed papillary stenosis, extrahepatic biliary duct dilation to 12 millimeters, and diffuse intrahepatic sclerosing cholangitis. Biliary sphincterotomy and stent placement were performed during this procedure. All these findings proved consistent with type 3 sclerosing cholangitis secondary to AIDS cholangiopathy, most likely from Cryptosporidium. The patient had stool cultures test positive for Cryptosporidium 5 months before this admission, and additionally had a stool specimen test positive for Cryptosporidium antigen 3 months after the current admission. The patient was eventually treated with appropriate antibiotics and was attempted to be maintained on heart therapy but failed due to patient noncompliance. The patient eventually passed away from complications arising from HIV/AIDS. Today we hope to discuss the etiology of AIDS cholangiopathy due to local tissue inflammation from opportunistic infections. Cryptosporidium is the most common pathogen associated with AIDS cholangiopathy and has been isolated in 20 to 57% of patients. As seen in our case, patients with HIV/AIDS presenting with nausea, vomiting, abdominal pain, and transaminitis should prompt evaluation for AIDS cholangiopathy with imaging such as ultrasound, CT, or MRCP, in which characteristic changes of the biliary tree can be observed. These changes include dilation of the intrahepatic and extrahepatic ducts, a dilated common bile duct, or a beaded appearance of the biliary tree without evidence of obstructive pathology such as stones. Treatment of opportunistic infections in AIDS cholangiopathy has proven surprisingly ineffective. The most effective treatment has been shown to be restoration of immune function using heart therapy. Failure to do so may cause further complications such as cholangiocarcinoma in the setting of long-term biliary inflammation.